We will kick off the 2022 President's Year of Service with tonight's CE presentation on integrating special needs patients in a general dentist practice in order to improve access to care. It gives me great joy to welcome Dr. Yogita Thakur, our esteemed speaker tonight. Dr. Thakur is the Dental Director of Ravenswood Family Health Center in East Palo Alto, California, since 2010. During the time I have known her, I've seen her work tirelessly to significantly increase access to dental care and strive for a high standard of care for her patients. In 2011, she secured a hospital relationship with Stanford so that children with the most severe medical and dental needs can get comprehensive care. She served as the medical director of dental services at Stanford and volunteered for several years in their craniofacial clinic, helping to improve the quality of life for those with rare genetic craniofacial disorders. Dr. Thakur leads the way in advocating for local dental health, having served in many roles on the San Mateo County Oral Health Coalition. She established the Virtual Dental Health Project with San Mateo County Head Start sites so that high-risk children are screened and families counseled early and often, with the goal of reducing the burden of caries. As an educator, Dr. Thakur also inspires the next generation of providers. She has given dental lectures for our medical colleagues at Stanford University, strengthening interprofessional education and collaboration. Dr. Thakur has proven strong leadership and a demonstrated immeasurable dedication to service, public health dentistry, and her community at large. Please join me in welcoming my friend, Dr. Thakur. Yogita, take it away.
Congratulations, Shakalpi, and thank you so much for having me here today. It's a privilege and honor to be a part of your celebration. Thank you very much, everyone. And I would say we'll hold questions for the end, but feel free to put them in the chat. What I would like for you to take away today is how we have been able to successfully manage patients with special needs in our general dental practice. You heard from Dr. Pendurkar that we do have access to the operating room, but that's not the only way to serve this population, and that's what I hope you take away. And each one of us is able to look to see what is it that we can do differently in our practices going forward. Disclosures, I have none to disclose. I will not be talking about or promoting any particular brand or company today. I present information on special healthcare needs and considerations for maintaining good oral health. I do work and serve on coalition and networks with network with others in the medical profession as a whole. I was talking to Candace earlier today, and I told her it's actually, I think, one of my very few presentations to dentists on how to work with patients with special needs. I have worked tirelessly over the years to work with physicians to recognize that don't send these kids to me when they have a cavity or when they have a toothache. Send them to me earlier on so I can establish care and do more of prevention and have better overall health outcomes. I do have a lot of direct experience working with these children and adults with special needs, and also in turn with their caregivers and medical providers. Even though I am a trained pediatric dentist, we at Ravenswood continue to see these patients as they age out of our practice, age out of being seen with a pediatric dentist. So I do continue to see several patients who are older than 18 or 21, wherever you decide to draw the line for pediatric dentistry. So special healthcare needs. The AAPD defines it as special care needs could be physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment that requires medical management, increased intervention, specialized services, and programs. to serve them, to serve their medical needs. The conditions may be developmental or acquired. A brief overview of what those conditions might look like. So from a behavioral standpoint, it's anxiety, ADHD, conditions on the autism spectrum. Congenital could be syndromes like Down syndrome and other medical conditions which a child is usually born with. Congenital heart disease, for instance. Developmental conditions are mostly cerebral palsy, and there are other development conditions that would affect the orofacial complex only, such as cleft lip and palate, amelogenesis imperfecta or dentinogenesis imperfecta, and of course, systemic diseases such as cancer, sickle cell disease, hemophilia, renal disease, immune suppression. It's very hard to put things in these 4 buckets because in many instances, there is overlap and multiple conditions occur concurrently. Some conditions develop because of an underlying condition, which may be developmental or congenital, and I will review that later as we progress today. This is just a way to classify conditions, but people live with there are individuals who could fit in all of these 4 buckets. And as I think about that, I have several patients with Down syndrome who have who are on the spectrum, have intellectual disability, and have autism. They have a cleft and also developed a non-Hodgkin's lymphoma as they were older. So they essentially could be classified in any 4 of these buckets. So a brief overview from a public health standpoint. What does it mean? We kind of think of special needs as a group out there, but what does that really mean? And what, in terms of numbers, are they really out there or are they amongst us? The 2017-18 data from Maternal Child Health reports there are about 13.6 million children that have a special care need living in the United States. 1 in 4 have functional limitations, which is that they cannot perform their daily duties of normal functioning life. 1 in 5 are significantly impacted by their health conditions. And 1 in 4 adult is living with a disability in the United States. Another benchmark, the Healthy People 2030 objective, it talks about increasing the proportion of children and adolescents with special care needs who have a system of care. These are very recent objectives. They were looking at them. It says, in the next 8 years or so, we want to make that number go up from the existing 15.7 to less than 20%. Thinking of this population and thinking of the increase that we're looking for, even though it's 5 percentage points, it requires a significant amount of work in all the systems of care as we look at having a better overall outcomes, better quality of life for our patients. I say that because, several times oral health does not even, kind of gets left out as being counted as part of the system of care. But we all know we're not healthy if we don't have healthy teeth. So oral health is a part and parcel of this system of care. And oral health has direct and sometimes devastating effects on the quality of life and overall health. In my time as a practicing dentist, I have seen so many children and adults with special needs who were not able to get sometimes life-saving surgical procedures because they were waiting to get dental care to have better outcomes after their surgery. You all know that if a patient has a mouth full of decay, they actually will not have a surgical procedure that that could be life-saving, either a heart transplant, a liver transplant, until the teeth are fixed because of the increased risk of infection and the bacteremia that the burden of dental disease causes. The unmet dental health needs are associated with healthcare need status and complexity for these patients. So those with highly complex medical conditions and multiple comorbidities are therefore at an increased risk of having unmet dental needs. Barriers to care are many and can range from limitations in access to a dentist who's willing and able to provide care, to financial barriers from insurance to coverage, or structural, psychosocial, cultural considerations. They can also impact access. Caregiver understanding for the need for routine dental services and the patient's ability to tolerate the care. And what does that look like? All impact the oral health status. So it's no surprise that oral health is the most common unmet healthcare need for children with special needs in the United States. Developmental disabilities and disabilities among people from low-income and ethnic minorities actually further complicate and create more barriers to care, leading to poor oral health status and outcomes. I want to take you back to that access to care and public health background comment by Dr. Kumar. I have worked, just like Dr. Pendurkar, in communities where low-income and ethnic minorities are served, and have had the opportunity to see firsthand what not having access to care looks like. And if you add medical complexities and developmental disabilities on top of the already existing barriers that our low-income families face, the effects are very devastating and can be life-changing in some cases. So why do we really care about having the general dentist look to see how we can serve this population? So traditionally, the care for special healthcare needs patients has been limited to the schools, the surgery centers, large hospital centers, and needless to say, with a big population of people with special needs, there's not enough capacity to serve everyone and to serve them well. So not everyone needs to be seen under sedation or general anesthesia. Dentists in private practice can play a very important role in eliminating these disparities for this really critical population. And this is our opportunity to be family-centered, as we may already be serving, the family members of these patients who come to our practice. So I'm going to start, I will now go on to a brief review of the medical conditions and talk about some of the dental considerations. So intellectual developmental disability, it is usually something that's established before the patient turns 18 and is expected to continue indefinitely, usually identified much earlier on. This is a federal definition before the patient turns 18. And it does include mental retardation. A level of functioning is significantly lower than that of their chronological age, and the IQ is lower than 70. So common conditions that we see with intellectual disabilities: autism, cerebral palsy, Down syndrome, epilepsy. All of these, and I shared with you the statistics, 1 in 44 births by age 8 are diagnosed with autism in the United States. This is one of the more recent statistics. Cerebral palsy is about two per 1,000 births, and Down syndrome is another 1 in 700 births is diagnosed in the United States to have Down syndrome. Autism, it is a developmental disability. It's got a wide range of presentations, hence it's called the autism spectrum disease. Some of the common things that we see is that the person with autism will avoid eye contact, prefers to be alone, inappropriate reactions to situations, socially awkward or socially inept to deal with multiple people, or work in a group setting. They have a propensity towards repetitive actions, and also sensory sensitivity to touch, to light, to loud noises, and splinter skills. Splinter skills are things that, facts that they might be able to remember and recall, but not being able to connect to why that is important. And as we see all of these things in terms of their medical presentation, think of the dental office, all the sensory sensitivity, the repetitive actions, people being in close contact. So kind of like thinking of how do we approach these patients? Oral manifestations, sometimes there is malocclusion, oral aversion, habits like lip biting, tongue biting, anything, because they have the propensity towards developing repetitive actions. Bruxism, those are very commonly reported conditions from an oral standpoint for patients with autism. Some of the treatment considerations, like I said, autism is a spectrum. Some patients do not present with a whole lot of symptoms, and others may have very extreme presentation of the disease and be very low functioning. So they can be from low functioning to high functioning, in terms of their intellectual ability. Some of the things that work really well in kind of having how the office is set up is, and how we approach seeing these patients, is to avoid bright lights, avoid overstimulation, keep instructions simple, one task after another. After the first one is completed, tell, show, do. And some of these kids do really well in a papoose board. Cerebral palsy, it's a chronic disorder of movement or coordination, which is caused by injury to the immature brain, either during prenatal or very, very early perinatal period. It's a static encephalopathy. That is, the original brain lesion does not progress or enlarge after the damage has occurred. It is a permanent, non-progressive movement disorder caused by damage to the developing brain, either during pregnancy or early life. Sometimes trauma during childbirth. Associated conditions, intellectual disability, seizure disorder, vision and hearing impairment, speech impaired or speech delays, or dysphagia, failure to thrive, orthopedic deformities, several times are wheelchair bound, feeding difficulties, and or have G-tube, or are dependent on a G-tube, chronic airway disease. Oral manifestations, malocclusion. A lot of that is a result, not as much of cerebral palsy, but because of what follows. Like I said, they have feeding difficulties, or they do not, or they're not fed through the mouth at all. So that leads to malocclusion of the developing dentition, because there is no stimulation to the oral cavity. Enamel defects, teeth develop at the same time, in utero as other organs in the body are developing. And if there are aberrations or things that happen during the intrauterine life, that can also cause enamel defects. Bruxism, mostly as part of some of the repetitive behaviors. Drooling, or excessive drooling, very commonly seen with patients with CP because of inadequate control. Increased propensity for trauma. Several of these patients do have seizure disorders as well. So trauma can be sustained to any parts of the body, mostly and also to the teeth. Gingivitis, mostly secondary, but will develop from either not enough stimulation and not enough clearing of the oral cavity. Treatment considerations say patients with CP have a low muscle tone. So therefore, they are at a higher risk of developing aspiration pneumonia. If they're G-tube fed, the calcium and the phosphate deposits from the saliva deposit on the teeth to create increased calculus deposits. If they're wheelchair bound, they can be treated in their wheelchair or transported to the dental chair with a high volume suction. That's another thing in terms of treating somebody with a higher risk for aspiration pneumonia. You want to have a high volume suction available to clear the fluids from the mouth. Frequent recalls to remove the calculus and promote oral health. One of the things I learned very, very early on serving this population was you remove the calculus from around the gingival margin of the teeth and leave the calculus on the occlusal surfaces to act as a sealant, because with feeding difficulties and being on a G-tube, several of these patients also have acid reflux. And because if the calculus actually will help save the teeth from the acid reflux and the repeated attacks of the acid in the oral cavity. So that's something to kind of think of as a practical application as we see these patients. Down syndrome, trisomy 21, it's associated with growth delays, moderate to severe mental retardation, congenital heart defects, and cervical spine instability, more in the atlantoaxial region, higher up in the neck. Oral manifestations, macroglossia and fissured tongue, usually low caries risk, but they're at a higher risk of developing periodontal disease. Enamel defects, have a class 3 malocclusion tendency. Part of it is how the tongue is positioned, and also, several of them have a low muscle tone. Treatment considerations. I say check with the physician for precautions and need for anything if they have an underlying cardiac condition, need for SB prophylaxis or other precautions that may be necessary. Avoid overextending the neck during dental treatment, and frequent recalls to identify problems earlier, and also to be able to promote a prevention. Seizure or epilepsy disorder. Certain populations are at a higher risk, such as children with intellectual disability or cerebral palsy, Alzheimer's, or patients who've suffered a stroke do also develop seizure disorders later on in life. Oral manifestations, gingival hyperplasia, mostly because of the medications they are on, and to control the seizure. Seizure medications available nowadays really have helped with seizure, managing the seizures very well. Gingival hyperplasia seen more when there is inadequate plaque control. And if we're able to improve the oral hygiene, the gingival hyperplasia can be kept in check. Xerostomia, a lot of these medications do dry the mouth. And so there are considerations to think about what, either clearing the mouth after the medication or using xylitol or other salivary substitutes. Oral trauma, which is usually secondary to have experienced a seizure. Treatment considerations for someone with a seizure disorder, to obtain a detailed medical history to understand what the triggers are. Triggers could be anything, could be looking at bright light, fatigue, stress, pain, an accidental IV injection of the local anesthetic. Have the emergency cart available when we're seeing these patients in our practice, and know how to handle a seizure emergency. So, some of the things to kind of consider, what does it mean to handle a seizure emergency? It is, it's about, keeping the patient safe until medical help arrives. So clear the instruments away from the table, place the dental chair or wherever the patient is in a supine position. Try and avoid moving the patient at that time. Have the chair as close as possible to the ground. Place the patient on their side to minimize a chance for aspiration. Don't put anything in their mouth to try and protect the tongue or anything at that time when they're seizing. Monitor the patient and call 911. Limit treatment after they've had a seizure. It's good to not continue with dental treatment after. Examine the mouth to see if there were any injuries sustained. Discharge the patient with an adult who is aware and alert and knows about what happened, or to the emergency department. Systemic diseases. Presentations will vary based on symptoms involved. It may be associated with immune suppression. Really knowing what the extent of the condition is very helpful. Treatment considerations. Medical consult. I like to say medical consult and not a clearance, because I don't really need anybody to, we as dentists don't need anybody to clear us to see a patient. It's our, whether we can do the procedure or not is, really based on our own comfort. To do the procedure safely is what we're looking for, and to consult with our medical providers as peers to understand what it is, what it is that I want to do and plan to do, and how does that fit in the whole global picture of this particular patient. So labs sometimes help, a complete blood count with differential is helpful for, planning care for somebody who has anemia or platelet disorder, leukemia, or is, undergoing chemotherapy. You want to know that they will be, they are not immune suppressed at the time of when they get the care. You want to, it helps you decide on the timing of treatment. It's not necessarily helpful as indicators for bleeding time, clotting time, or whether to take a patient on and off a medication like aspirin or Plavix or one of the blood thinners. That's not what we're really using that for. That's the piece that we can, regarding medications and interactions, is something we consult during, we work with our medical colleagues on. And also I point this out, medical consult and not clearance, because a while back, one of my colleagues actually shared, and I've read about this as well, but I remember them saying, a clearance is not going to help me if something was to go wrong and for a patient, and then you were in a medical legal situation. It's not going to be like, oh, the physician said I could do it. Well, but where was my, what was my personal evaluation? So that's why I like to use the term medical consult rather than medical clearance. Conditions that either affect the orofacial complex by itself, or other, may have other systemic effects as well, but things like the cleft lip and or palate, golden heart syndrome, where DiGeorge syndrome, Pierre-Robin sequence, Apert, Cruzon, amelogenesis imperfecta, dentinogenesis imperfecta, ectodermal dysplasia, where the teeth are mostly involved and require more and extensive treatment planning and thinking unconventionally or outside the box to provide care. These are some of my patients that I have seen with craniofacial conditions, and continue to see them now. They're both older kids now in orthodontic treatment and have done really well. Craniofacial conditions may or may not be associated with intellectual disability. They may be associated with other systemic manifestations, like I talked about earlier. However, they do have oral manifestations, which may make it harder to see these kids in the practice because of oral aversion. They often have enamel defects, supernumerary teeth, missing teeth, malocclusion, and are at a higher risk of caries because of all of those things put together. Treatment considerations: early establishing care, or establishing care early, and periodic assessments, risk assessment with goal settings. I can't speak enough for both of those two pieces because, like I said, and you all know this, if we get them when they have cavities, and then our focus is on restoring and taking out the hopeless teeth. But when we have when we get them early in our practice, we actually have the opportunity to work with the family, caregiver, and the patient to assess risks, make small changes to their lifestyle that can hopefully prevent the need for a lot of treatment. For craniofacial conditions, we try our best to restore teeth over extractions because restored teeth are keep the surrounding bone around the teeth. And with extraction, there is some bone loss as the site heals and bone remodels. And restoring teeth over extractions helps in the future when the patient is ready for bone grafts and things like that. It's a smaller defect to fill. It's a smaller, it's a better outcome for the patient. So all of those things, kind of help the patient have a better quality of life in the future. Work very closely with the craniofacial teams to plan the care and see how things align, both with timing and with the kinds of things that may be needed. In summary, what are some of the health challenges with our patients with special needs? We have to consider mental capability, behavior problems, mobility problems, neuromuscular issues, uncontrolled body movement, heart disorders, GERD, seizures, impairments with hearing or visual or sight. And all of those things kind of put together inform how we see these patients in our practice. And so the how do we translate all this that we know into practical dental applications? So treatment consideration, work with the medical team to create a plan of care, not just limited to the medical clearance, like I said earlier. Work with the family and the patients. I think it is really important to know where the family stands in terms of what they want for the patient. Consider, drug interactions, long-term goals for the patient and the parent, and how do we promote and weave in the preventive regimens in terms of, frequent recall or, fluoride varnish applications in the office, or using a high concentration fluoride toothpaste, for example, at home. In terms of and in terms of like the medical consult and conversations with the medical team, like I said earlier, I've spent a lot of time working with my medical colleagues trying to have them send these patients to us sooner. And so promote that idea, not just for the patient you're seeing, but also those that may follow in the future. So the idea of early establishment of a dental home is critical. And we all know this as dentists, but something that helps kind of frame it for our medical colleagues is we're surgeons, but we're still primary care providers, both at the same time. While my surgical skills come in handy when the teeth are broken or they have cavities, I have a preventive skill set that I can use when when the patient does not have the immediate oral health needs. So things to think about as we bring the patient in for an appointment. Who is the patient's legal guardian? Who's going to consent to the treatment? Is it the patient? Is it the parent? Is it the legal guardian? Does they live in a group home? Is it the person at the group home? And who has that legal authority to make the decisions? And of course, consent, both general and specific, like we always do in dentistry. Getting in as much information ahead of time as on oral hygiene practices. What is the most current and up-to-date medical history, list of medications? What is the chief complaint? What are we trying to address today? And, with a lot of these patients, there are limitations in terms of either their speech or, some of them have very high pain tolerance. So finding out from the caretaker, as in, how would you know that the patient is in pain? And I tell you, that is like the answers you get with that are really profound and thought-provoking, because it's amazing how caretakers can tell you, I know that they're in pain because they're doing X, Y, and Z, or that there's some kind of a discomfort. It may or may not be dental related when they're slapping their face, but it could be. And I bring that up because I had a patient, 15-year-old, was suddenly slapping his face, saw him twice in the dental office. He has autism, was G-tube fed, and had been a patient of our practice for several years. Kept trying to figure out what it was that was bothering him. I couldn't see anything in the mouth. The physician called me and said, well, would you want to take a look again? Because, he is slapping the left side of his face. And I said, sure, I'd be happy to look again, but I've done it already and I don't see what the issue is just yet. I mean, I can't identify anything. We've even been able to take x-rays. Would you consider antibiotics or something else? Could it be a sinus infection? So sometimes it is a little bit of a guess game and you have to go back and forth. Ended up that he had a shunt from his brain, which was leaking, and it was positioned on the left side. And that was what was bothering him. So I feel good about being part of this kid's care because we were able to get in early and look and see that it was not related to dental. So the medical team could then focus on, looking for other causes that may be causing the problem. Past dental experiences, any special accommodations that the patient needs, and what is the caretaker's expectation of the appointment. You'll hear me talk about that more and more as we go through the rest of my presentation, in part because that is a very important pillar in my mind of success of having these patients in our practice. Here's something we use. This is a pre-visit questionnaire that our front office uses. This is a form that I first saw or read about from University of Washington's autism clinic. And I thought this was like a great way to get as much information as you can before the patient comes in. Their form, of course, was much lengthier. We've kind of shortened the form to serve our needs, and essentially use this to help us guide the first appointment. kind of help us decide how long of an appointment do I need, where where would I want to see this patient, in an open space, closed room. Would a morning appointment be better? Would an afternoon appointment be better? Based on what we first hear, and any adjuncts that we may need, in terms of a papoose board or some kind of a restraint. How do we want the lights to be in the room when the patient comes in? Or do I need the picture cue book if there is, if the patient can be engaged and but is nonverbal? So patient assessment, we try and gather as much information as we can prior to the visit, and then revisit at the time of the first visit to see if they match. Sometimes parental perception or assessment of ability is not what we see in the office. Now, there could be many reasons for that too. It could be because it's a new environment, you're new, the patient is meeting you for the first time, they don't know how to react, or that it's a whole different, or that something else happened between the time you did the pre-assessment to now, which has changed the patient's ability to cope. So patient assessment, kind of more in depth about communication ability, and how do they react to stimuli such as noise or touch or bright light. I'm a pediatric dentist. I may have a kid in the next room screaming as this patient is being brought back. Now that can, scare anyone. It can scare us adults too. So, or, kind of put us on a high watch. So have to be kind of sensitive to all of those pieces. Previous dental experiences, and if they've had dental emergencies and how those were dealt with in the past. Clinical examination, it's what we strive for is to get as close as possible to our norm of what we do for any one of our patients. So an intraoral and extraoral exam, hard tissue and soft tissue examination, understanding of the caries risk assessment, fluoride exposure, diet and oral hygiene, oral cancer screening, and status of soft tissues and teeth, including caries, mobility, fractures, calculus deposits, etc. However, they may not be as straightforward and easily done in one appointment, or you might need some additional tools. So I have pictures here of like a molt mouth gag or a bite block, or a tongue repressor that's wrapped with gauze on one end. Could also use a toothbrush to help keep the mouth open on one side while we examine the other side. Some of the behavior guidance techniques on how to have a successful visit, tell, show, do. Again, kind of reminding us, when there is intellectual disability, intellectual ability and their chronological age do not match. So it's almost like you're seeing a kid all the time. They may be 20 or 30 years old, but the mental ability is of someone who is much younger. So tell, show, do works well. Firm voice control sometimes is also needed. Physical restraint, it could be a papoose, it could be a person holding them, it could be the parent holding them. If they're small enough, it could be a knee-to-knee visit as well. These are all ways of successfully managing a patient. Not all patients are a candidate for any of these situations. For example, a patient with osteogenesis imperfecta that impacts the bones, and where the bones can fracture easily, may not be a candidate for a physical restraint. Somebody with a advanced heart condition may not be a candidate for an in-office sedation or even in-office general anesthesia and may require a hospital setting. Somebody with autism who's not able to, and who's low functioning could, may need a physical restraint and a sedation to even just successfully do a good exam and a cleaning. And for some, it's like all of the above. Everything is needed to do an exam and a cleaning. I could get away with like a Talshel do. For a simple filling, they may need a physical restraint, but to extract an impacted tooth, they may either need a sedation or general anesthesia. Treatment planning, just general ideas around this. Patient-centered care. Start with the ideal, but then kind of put it in the realistic picture frame, is how I say it, because you want to say, what is ideal? Does that fit my patient's ability, not just to actually do the procedure in the operating room, but also can they maintain all the investment in the oral health, in the work that we are going to do. The commitment to oral hygiene, and of course, with a focus on prevention and preservation. Restorative material choices become really important for our patients with special needs. If they have an enamel or a dentin defect, composites don't always bond the same way that they bond to normal enamels. So, the restorations fall out. A composite restoration may fall out in a very short period of time. So therefore, glass ionomers or amalgam or full coverage restorations seem to be a better fit in terms of how to restore some of these patients. And other things to consider is, would the proposed treatment induce stress? And does it put the patient at risk for other complications? If the patient has cerebral palsy and has extreme limitations, could we be putting them at a higher risk of pneumonia with general anesthesia? Our parents will sometimes tell you they do not want their child to be put under for a cleaning, while others might say, well, that's the only way they've had cleaning all these years, and that's how they want it now. So parent and caretaker expectation is also key, but all of these pieces are equally important as we continue to think about our treatment planning. Clinical documentation. It's really important to document progress that we made at the visit. Our notes help us kind of build on the previous visit. So it helps us to plan for the future visit. It sometimes helps us if we document like in real detail, then it helps us kind of figure out, was a morning visit really as successful as it had to be? If you can look back to see, well, I saw them in the morning and how did it work in the afternoon, and versus an afternoon appointment in the past. So, and also what progress they were able to make. I have several patients who, will not walk into the operatory, or will walk into the operatory and not sit in the dental chair. But they will still let you get close to them and have a conversation of some sort. You can show them certain things and things like that. So it's really important because it builds on the next builds for you for the next visit. So some of the things we document was who accompanied them to the visit and how engaged they were, timing of the visit and how they did for the visit, and plan for the next time. Like if the patient didn't sit in the chair, did not even sit on the dental chair, there's no point having a papoose laid out next time, because the chance of that happening is really low. But if we were able to have them sit next to the parent and let us look in their mouth, maybe they will let us clean their teeth while they're sitting next to the parent the next time, or the caregiver next time. And will helps kind of think through any adaptations to the visit for the future. Referrals. Patient safety is key, and refer when treatment cannot be rendered ethically and safely. While we want to see these kids and adults in our practice and integrate as much as possible, those two pieces are also key. Local referrals, in my mind, are the ones that are most commonly utilized. But again, there's not always a local resource available. Dental schools have resources, but their wait lists are really long. So do we refer for everything? Do we refer for the pieces that we can't do? I think that's kind of like the piece that I have always struggled with, and felt like let's refer only for what we can't do and keep what we can do. So if I can see them in my clinic for a cleaning, I would rather do that. But if I cannot safely do the restorative work, we should refer out. Or in our case, do that part under general anesthesia or sedation, because we're fortunate to have that as part of our service package. These are some modifications and accommodations kind of talking about just showing the parents. A lot of times the parents and the caregivers will say that they cannot take care of that. They cannot brush because they don't know how. And so just like the positioning or having them in the wheelchair and the parent standing behind and somebody else helping. These are kind of modifications and accommodations that we've had to use in our clinic as well, but also works well for parents to take home. Other accommodations to think about are toothbrushes. What kind of toothbrush? What kind of a grip do we want? For that'll help with adequate plaque removal. On the bottom here, the picture with a little pump on the lower right, that is a toothbrush that actually attaches to a suction to a suction. So if the patient has a G tube or a trach tube, and the families usually have a suction machine at home, they can use this to take away the toothpaste and the saliva, and reduce the risk for aspiration. Surround toothbrushes seem to be really helpful as well, because they can get to multiple surfaces of the teeth at once. These are some adaptations for a larger grip for older patients who are able to manipulate a toothbrush themselves, but find the grip to not be sufficient enough, in terms of to be able to hold. So a tennis ball or a cloth or a bike handle, anything like that to hold added to one end can help the patients grip it and perform oral hygiene. Briefly, I will tell you about where I practice and how we've been able to integrate special needs patients in our practice. So we're a federally qualified health center in East Palo Alto. Our clinics have served the community for over 11 years, and we offer comprehensive dental services. We have medical clinics in Santa Clara and San Mateo County, but our dental clinics are in East Palo Alto. And our mission is to improve the health of the community by providing culturally sensitive, integrated primary and preventive care. Needless to say, our special needs patients are part of the community, and that's how we want to keep them and serve them. So what we offer in terms of services is comprehensive dental services for patients across the lifespan, oral sedation and general anesthesia. We do serve children and adults with special needs. And even prior to the pandemic, we utilized asynchronous teledentistry, doing virtual dental home with the effort of expanding preventive access to preventive services in the community. We continue to do that now. We do that more so for other purposes as well. And I have found that managing some of my special needs patients through teledentistry also has been very valuable. How do we do what we do? I'm very proud and honored to work with a group of providers and staff who are committed to serving our population. We've built partnerships with local programs that serve the community, so the word gets out as what we do and how we can help. We have an AGD residency in collaboration with NYU and UCSF. So that gives us an opportunity to teach young dentists graduating and seeing how they could integrate infant oral care and special needs, and as well geriatric care in their practices in the future. We look at QA and QI and constantly look to improve our services based on feedback and, of course, clinical adaptations. And an important piece is advocacy, because if we want our patients to have the care they need, we also have to be one of their advocates along with their caretakers. Just some, the facility considerations. Our buildings are built to code, everything's ADA compliant. However, when we first started to see these patients in our practice, we realized there was not enough space between to accommodate the wheelchair. So in the picture in the middle, you see me sitting on the dental chair while working on the patient who is in a wheelchair. When we had the opportunity to expand our clinics, we took that into consideration and now have rooms that are larger and can accommodate a wheelchair side by side very comfortably and allow for ergonomics for both the provider and the assistant. The open bay, that had its own challenges, and both from a patient privacy issues, but also families felt very self-conscious, especially if there were patients who had either themselves or their child had special needs and they looked different, they felt awkward in that open space. And not to talk about the HIPAA violation. So things of those nature we kind of took into consideration, both in terms of our building space, but also how we scheduled these patients so that we had a closed room available to see them and offer them the privacy. So foundations of, how one of the thoughts that we had was patients often gave us history of dental treatment under general anesthesia with not much follow-up in between. So that was an important piece in our mind that had to change if we wanted to maintain their oral health. kind of trying to adapt on all of those levels. Well, could you do treatment with a papoose in the office? Could you see them for preventive and non-invasive treatment or non-invasive visits in the office, and extend the gap between the times that they will need general anesthesia? So what were some of the goals of a treatment visit? It wasn't an all or none. It was, we kind of realize the limitations of the special needs population, and we say it's what the child can cope with and whatever they can handle. That's how we go. That's how far we want to go. The dentist is leading the patient to make the progress, not necessarily all in the same visit. And like I said earlier, parents can be our biggest partners, but can also sometimes be the reason why the visits don't go as planned. And that, in my mind, happens when our parents dictate the amount of treatment. We've waited 4 months to come see you. Today we want you to do an exam, x-rays, and cleaning, and the patient is, hiding under a chair and screaming. I don't know that I could even do an exam. I leave alone the x-rays and the cleaning. And then there's, of course, that conversation needs to happen with the parent or the caretaker to say, well, we want to meet the patient where they are and get them to help us get to all of those things and more. But I can't promise all of that today. So what is our philosophy at Ravenswood? We believe everyone deserves the best possible care. Our clinic was founded to address the oral health disparities in our community, and that's what we've strived to do. Having the dentists who've had the interest in working with patients with special needs sort of address the first, the barrier, like everyone deserves the best possible care. We can do that because we have dentists and staff who are able to do that. We also want to promote health equity with the central theme of building trust and working with families to improve oral health rather than take care of dental problems alone. And so getting dental treatment under sedation and GA is not the norm. It's needed, but it's not the only way that we can see these patients. So we can integrate preventive care in our practices for special needs patients and build the trust and establish a dental home. I want to share with you my special needs, my patient with Down syndrome and significant intellectual deficit. And she is proof that visits build on each other, and these kids or adults have a way of processing and remembering things, and can be taught to be integrated in a dental practice. She came in for the first time with her parents at age 3. We did a knee-to-knee exam, and it was a successful visit, and had several successful visits in the future. Suddenly, she became extremely phobic at 5, and she wouldn't come out from behind the mom's. She was holding onto her mom's pants and would not even look at me or my assistant. And at that point, it was a conversation with the parents. What happened? What happened between the last visit and now? And well, maybe we should see her back sooner next time and see if what might work. See if that'll work. Have a conversation around things at home. At the follow-up visit, she came back. It was a non-traumatic visit. She was standing, screaming and crying, but we kind of had focused our visit with the parent. So at some level, there is some understanding of like, this was non-threatening, really nothing happened. And so at the follow-up visit, she agreed to hold a pen light and let us look in her mouth. And at subsequent follow-up visits, she's sat in a dental chair for sealants and comes in for her cleanings regularly. This is Arturo. He is a special needs patient with autism, nonverbal, severe autism, low functioning, and also very high pain tolerance. So mom didn't know until she came in that he was having problems with some of his teeth, but she did notice issues with she noticed there was change in behavior. Extremely anxious and sensitive to noises and smell. How do we get away from that with in a dental office? Still working and figuring that part out. But several desensitization visits later, he returns every 4 months for a cleaning and did very well with a sedation to restore an anterior front tooth. This is Damien. He has a history of developmental delay, autism, and osteogenesis imperfecta. He was very fortunate to have a dentist in the community who saw him until he turned 17, and his dentist at that point retired, and asked the parents to take him to the dental schools. The parents were told one dental school that the wait list was really long, and another dental school said they didn't accept patients over 17. So they really thought that, so it took them a while until they found us. And at that point, the parents were really convinced that the patient will only tolerate general anesthesia, even though he had been seen in a dental office all the while. Had really good oral hygiene. Parents are very involved in care. And so we did one general anesthesia visit in 2015. And at that point, convinced the parents to say, like, for follow-up visits, bring him into the office. Now he comes in every 6 months for regular cleanings. He's caries free. We work with his pediatrician and his medical doctor now, since he's transitioned from pediatrics, to kind of set guidelines on what we can and cannot do in the office. And he's been a part of our practice ever since, and continues to do well. Here's my email address, and I just want to leave you with some food for thought. How do we encourage each other to do this, and how do we learn from each other? A journal club seems like a great idea. A medical update CEs. I'm fortunate that the AAPD offers it as part of the annual meeting. Usually there is a medical update session, which is a full day around medical conditions and considerations. And that is, I find, very helpful to kind of frame oral health as part of the overall medical concerns for the patients, and collaborate with other dentists. We all can do this together. Here are some resources, and
thank you, Dr. Thakur. That was an amazing, amazing presentation. Thank you so much. Yogita, I've known you for so many years, and doesn't surprise me. It's very touching, actually, to see everything you do. I've always said this, not just to you, but to others as well. If you cannot see a child, if there's a problem and there's a difficult patient that you absolutely don't know, what do? You reach out to Yogita. She'll see that patient. But we cannot clone you. But I hope with today's presentation, we are all inspired, to do more and to try out some of those techniques before we make that referral. So thank you for sharing the presentation with us tonight. There are a couple of questions that Yogita, I would like to pose from the audience. Someone wants to have the resources slide again on the screen. If you can bring that up.
Yes, I can do that.
And then the question that was asked is, what is the leading cause of increase in the number of autistic children, in your opinion?
I think we know more about the disease now. We're identifying those sooner. I feel that's probably the reason why. Autism is such an interesting condition and disease that it's really hard to know. Like there's definitely a genetic component or there's an environmental component, but I think to look for signs of looking for signs, I think we are more diligent and we know more. And that's why I think the rate of diagnosis is higher. In the resources, I do want to point out the All Smiles Shine app. It's really new and you can download it on your phone. I recently learned about it. It's an app for like families to use, and also, you know, collect information that dentists will find helpful in terms of, you know, the things we talked about, resources and things like that. That the pre-appointment information that we're looking to collect. I believe it's still in testing phase, and it's very promising.
Also, you guys, if any of you are willing to take these patients, please let us know at the office, because their caregivers and parents call us quite frequently, and it's very heartbreaking because often their teeth are not in the best shape, and there aren't a lot of people who will take these type of patients, and they're really the ones that need to be seen the most in a lot of cases. So if you email me or someone else at the office and just let us know, we can mark that you take medically compromised or special needs children and adults, because that's a good thing for us to know for referrals.
Or even if you want to take just that one patient, even
Yeah.
if you're open to that, that's still going to make a difference. Thank you, Megan, for that.
Mm-hmm.
I don't see any other questions. Are there any other questions? You can raise your hand or type it in the Q&A box or the chat box. I think, Dr. Thakur, if you could share the slide with your email address again, that was a request, please.
Someone asked an ortho question somewhere in the chat.
I'm going to put can I put my email address in the chat?
Yes,
There.
please. There you go. Thank you.
Someone asked, is there any government supported plan that covers the orthodontic treatment for patients with developmental disabilities? I believe most orthodontists are not willing to accept Medi-Cal at this point, as they do not have any guarantee that Medi-Cal covers the long-term orthodontic treatment for patients.
So I believe Medi-Cal does cover orthodontics and there's so there's this HLD form, and I forget what the HLD stands for, but it's a Medi-Cal form that determines severity of orthodontic condition. So for if there's like a craniofacial defect or something like that, then it is like an automatic you rank or you score enough to qualify. However, I think the dentists may still need to do pre-authorization with Medi-Cal.
Yeah, I think if it affects their ability to digest or eat, then it does qualify for Medi-Cal under orthodontic treatment. At least that's what I've heard from our few orthodontists who take Medi-Cal, so more people should consider it.
Oh, absolutely. There's not enough orthodontists that take Medi-Cal. I know that for a fact. So yes, if you're interested, I think you should look into it.
Yeah.
Thank you. And it is very heartwarming. We have, Dr. Robinson posted in the chat box too. She's a pediatric dentist as well and agrees with what you're saying, Dr. Thakur. It is heartwarming to see the participation tonight because of the topic of the CE lecture. I think it's fair to say that most of us as providers want to help and have it in our hearts to do what we can to help the community, especially the special needs population. I know my friend Brooke, who has been chatting away in terms of what she does in Idaho, agrees with that. So like I said, even that one patient, if you want to take that one patient, it's going to go a long way in trying to improve what access to for these special needs populations. So I want to take this moment to just thank everyone again for celebrating with us. I want to thank Dr. Thakur for this great inspiring presentation tonight. And I don't know what's happening with the Niners. I hope they're winning. Carliza tried to keep me posted, but I'm not sure where we are at right now. So again, thanks for being here and not in front of the TV. But we will have a celebration in person. I know my friends and family from India and from Canada, from Dubai. I really, from the Middle East, I appreciate you all being here at all different times of the day, early in the morning. Thank you again. You're all very special to me. We will party in person as soon as it's safe to do so. And I hope to see most of you there. I want to again thank Baxter, the board, Candice, all our staff, and all my family again for being here tonight with me and for allowing me to serve and to advocate for our profession, for our members, and for our community. With that, I will say good night. And I will see you all again. Thank you.
Congratulations, Shakalpi.
Thank you very much. Take care, guys.
Have a good weekend, everyone.
Be safe. Thank you very much. Bye-bye.